Hello, future nurses. Welcome to this Next Generation NCLEX RN review session. In this episode, we'll tackle the management of post-operative complications. And this scenario is designed to hone your clinical judgment skills, challenging you to navigate complex data and make critical decisions using the clinical judgment measurement model. Let's dive in. Here's our first test type. We have a bow tie, and this is about a 52-year-old female transferred from the post-anesthesia care unit to the medical surgical unit post-open cholecystectomy for cholecystitis. So this patient had significant bleeding managed with 2 units of packed red blood cells with the vital signs: blood pressure 136/80, heart rate 98, respiration 16, and temperature of 99.8 degrees Fahrenheit, saturation of 93% on 2 liters via nasal cannula. Has currently abdominal dressing, which is dry, with JP drain with 40 mL of serosanguinous fluid, indwelling urine catheter with clear yellow urine. This patient has a history of hypertension, anxiety disorder, and recent financial stress. She's divorced, lives alone, non-smoker, no substance use history. Her mother has a history of type 2 diabetes, and father had coronary artery disease. Let's look into the care transfer data. Currently having post-operative pain, fatigue, anxiety. She has a BMI of 28.6. Allergies to penicillin, and currently takes lisinopril 10 milligrams daily, and also has an order for morphine PCA at 1.5 milligrams dose, 15-minute lockout, 20 milligrams every 4 hours, which is the maximum dose, and an order for ondansetron 4 milligrams IV PRN, nausea. We also have the past medical history here, including anxiety disorder, cholecystitis, hypertension, and mother has type 2 diabetes. I think this is already repeated. Then we have the following findings on her present medical history. So this is a lady who had post-open cholecystectomy for cholecystitis, had intraoperative bleeding, and she required 2 units of packed red blood cells, and transferred from the PACU with pain level of 6 out of 10, fatigue, saturation of 93% on 2 liters. She reports anxiety about recovery and finances. By day 1, midday, saturation dropped to 91%, respiration slowed, JP drain output increased to 60 ml serosanguinous fluid. Nausea emerged. On day 2, hemoglobin is 9.8 grams per deciliter. Nausea resolved with ondansetron. Pain reduced to 4 out of 10. Saturation improved to 94%, and she has mild epigastric discomfort. It's persisting, and now has reduced anxiety after social work consult. Let's look into the patient's physical exam on day 1 at 8 a.m. She's alert, fatigued, oriented ×3, with shallow breathing, clear breath sounds, tachycardic, no murmurs, has dry dressing, JP drain with 40 ml serosanguinous fluid, catheter draining clear yellow urine, has IV fluid infusing, that's dextrose 5 half normal saline at 100 mL per hour. To the left forearm, no redness and swelling. Let's look into the healthcare provider orders. We have orders for morphine PCA, a 1.5 milligram dose every 15-minute lockout, and 20 milligrams every 4 hours maximum dose. We have orders for lisinopril, ondansetron, PRN for nausea. Diagnostic tests. In abdominal ultrasound, we have CBC, comprehensive metabolic panel, PT-INR, continuous pulse oximetry, vital signs every 4 hours, and JP drain output every 8 hours. And an order for social work for psychosocial support, and gastroenterology for epigastric symptoms. Now, let's look into the patient's notes, or the nurse's progress notes for day 1 from 8:30, 12 noon, and then at 2000 at night. It said here, on day 1 at 8:30, patient transferred from PACU, blood pressure 136/80, heart rate 98, respiration 16, saturation 93 on 2 liters per nasal cannula, temp 99.8, pain 6 out of 10, fatigued, anxious, JP drained with 40 ml serosanguinous fluid, morphine PCA active, continuous pulse oximetry and respiratory assessments every 2 hours initiated. At 12 noon, saturation is 91%, respirations 14, temperature 99.9 degrees Fahrenheit, pain 6 out of 10, reports new nausea, increased oxygen to 3 liters nasal cannula, JP drain output 60 ml serosanguinous fluid, administered ondansetron 4 milligrams IV, notified provider. At 2000, saturation 90%, respirations 13, temperature 100.2, pain 6 out of 10, nausea persists, reports epigastric discomfort and fatigue, oxygen at 3 liters nasal cannula, JP drain output 80 ml serosanguinous fluid, provider notified, ordered CBC CMP and abdominal ultrasound. And let's look into day 2's nurse's progress notes. At 7 in the morning, blood pressure reads 148/90, heart rate 112, respirations 12, saturation 94 on 3 liters, nasal cannula, temperature 99.9 degrees Fahrenheit, hemoglobin 9.8, nausea resolved after ondansetron 4 milligrams IV, pain reduced to 4 out of 10 on morphine PCA, patient feels less fatigued, epigastric discomfort persists, described as mild, JP drain output 80 ml serosanguinous fluid over 8 hours, decreased from 100 ml, reduced anxiety after social work consult, patient states, I feel more hopeful about my recovery. Abdominal dressing dry and intact, continuous pulse oximetry continues, gastroenterology consult pending. And we have the vital signs from day 1 at 8 in the morning, 12 noon, 2000, and day 2 at 7 o'clock in the morning. So scan this by yourself. This will be very important information that you can use in the succeeding scenarios. All right, let's look into the hemoglobin. On day 1, the level was 10.5 grams per deciliter. On day 2, it's 90.8 grams per deciliter. Bilirubin on day 2 is 1.3 milligrams per deciliter. And the abdominal ultrasound done on day 2 showed perihepatic fluid collection. That's quite significant. Now here, we are doing a bow tie test item. You know the drill. We got boxes for the potential complication. We have 2 boxes for teaching point and 2 boxes for statement indicating understanding. So drag those appropriate boxes to its correct spot. We have the following options for potential complication. One is morphine overdose, pneumonia, pulmonary embolism, wound infection, bile leak. Now, go back into the scenario if you need to, but let's proceed right now. The correct answer for the complication is bile leak. Now, take a look into the scenario one more time. The patient is on day 2 post-cholecystectomy, and she's now showing some subtle but important signs. So she complained about mild epigastric discomfort and a slightly elevated bilirubin level. That is 1.3 milligrams per deciliter. And note about the increased JP drain output. Okay. Plus, the ultrasound showed perihepatic fluid. So these are classic signs of a bile leak, a known complication after gallbladder surgery. What's happening here is that bile is escaping into the peritoneal cavity instead of being properly drained into the digestive tract. So this can cause irritation, localized pain, rising bilirubin levels. Even though it's not always dramatic at first, this one can progress fast if not caught early. So the rest of the items or choices are incorrect. Now, if you selected wound infection, this might lean toward wound infection since the patient had surgery. We're only on day 2. And the wound is clean, it is dry, and she's having some mild fever around 99.9 degrees Fahrenheit, also on 100.2 degrees Fahrenheit. So this is not enough to say there's a local infection, because there's no redness, there's no drainage or swelling noted at the incision site either. So while the wound infection is something that would keep an eye on, it's not what the current findings are pointing to. So we are going to eliminate that. And pulmonary embolism is also incorrect, because this is something that could present as chest pain, there's shortness of breath, sharp drops in oxygen saturation. And in the case scenario, the patient has shallow breathing and saturation around 90 to 94%, but their lung sounds are clear and there's no acute dyspnea or chest discomfort. And this doesn't really add up to a PE. And remember, PE is very dramatic, and this is more subtle and abdominal. If you selected morphine overdose, this would raise concern if the patient were unresponsive, maybe pinpoint pupils, or showed signs of respiratory depression like respiratory rate below 8 or saturation in the 70s. But in this case, the patient is alert, she's breathing at normal rate around 12 to 16. She's not showing signs of sedation, so morphine overdose doesn't really play here. For pneumonia, another incorrect option. This is more about productive cough, abnormal lung sounds, crackles or rhonchi, and high fever. And there's no cough or changes on auscultation. There's just shallow breathing, which is common after surgery due to the pain on the incision site, especially that she got the open type of cholecystectomy. So again, this one doesn't really fit. Now let's move on into the 2 teaching points. Here are the options. Keep incision site clean and dry, report sudden chest pain or shortness of breath, avoid overuse of pain medication, perform deep breathing exercises, report fever or purulent drainage, and monitor for yellowing of skin and eyes. One of the answers that you should pick would be monitor for yellowing of skin and eyes, because this is really huge. When there's going to be bile leaking into the abdomen or bloodstream, the bilirubin starts to build up, and that's going to show up as jaundice. So when you are teaching the patient to watch for yellowing of their skin or the whites of their eyes or sclera, this is key. So it's one of the first visible signs of a bile leak getting worse. The other intervention that you should have picked is keep incision site clean and dry, even though the bile leak is internal. Any post-op complication can be worsened if there's also a skin infection. And teaching the patient how to properly care for the incision protects against secondary infection and promotes healing. And clean, dry incisions can help prevent unnecessary inflammation that could mask or confuse the assessment of the complications. Now, if you selected report fever or purulent drainage, that's a great advice to the patient, but this one is meant for wound infections, not bile leaks. And our patient doesn't have purulent drainage or clear signs of local infection. Even though fever is something that we monitor, this teaching point is going to be more appropriate when the incision is inflamed or is being infected. Now, if you selected perform deep breathing exercises, this is super helpful in preventing pneumonia or atelectasis, especially in post-op patients. But then again, we are dealing with a bioleak, not a respiratory complication. So this would not be our priority teaching point as well. And if you selected avoid overuse of pain medication, this is solid general advice, especially if we're worried about morphine overdose. But our patient is not showing signs of sedation or toxicity to the opioid. And this doesn't really tie into the bioleak prevention or recognition. Eliminate this one as well. Or if you selected report sudden chest pain or shortness of breath, this is something that you can advise to the patient if they are at risk for pulmonary embolism. But those symptoms do not connect with what we are seeing here. And the bioleak presents more with the abdominal symptoms that she is complaining about, and the laboratory change, it's not about respiratory distress. All right, let's head into the two statement indicating understanding. And the options that we have: I'll call if I feel sudden chest pain. I'll watch for redness or pus at my incision. I'll do deep breathing to keep my lungs clear. I'll report any swelling in my legs. I should take my pain medication only when needed. I'll let you know if my skin starts looking yellow. The answer would be that one. That's perfect, because this one shows the patient understands how to monitor for jaundice, which is a red flag for bile leakage. So we have taught them the why, and now they can watch for one of the most obvious signs. The other statement should be, I'll watch for redness or pus at my incision. Even though the main issue is internal, this shows the patient gets the importance of incision care, keeping an eye on the surgical site to catch any secondary problems early. And we love hearing this kind of proactive thinking as well. Now, the rest of the items or options are incorrect. So if you selected, I should take my pain medication only when needed, this kind of sounds responsible, right? But this is focused on pain control and morphine safety. It's not about bile leak detection. So it's not the best match for this scenario as well. Now, if you selected, I'll report any swelling in my legs, well, this would be a great advice if we are worried about DVT. But again, our concern is in the abdomen. It's not about the vascular system. The same thing with the statement, I'll do deep breathing to keep my lungs clear. This one is important if we are worried about post-op respiratory hygiene, which we often teach after abdominal or thoracic surgery. But this one doesn't really relate to the bile leakage, which is the real complication that we are trying to address. And lastly, if you selected, I'll call if I feel sudden chest pain. Again, this is perfect advice for the wrong scenario, because we know that sudden chest pain is a red flag for pulmonary embolism, not for bile leak. So this is important for other contexts, but it's not applicable for this situation. All right, review your rationales and make sure that you understand thoroughly what needs to be done, what needs to be assessed in this patient, or what needs to be the teaching points that you should follow through. Let's look into the second test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX Review Crash Course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
So we have the same information regarding the physical exam on day 1 at 8 in the morning for general, respiratory, cardio, abdomen, urinary, and IV. And we have already scanned this one as well, the nurse's progress notes from day 1, 8:30, 12 noon, up until 2000. So if you want to scan one more time, go ahead, but we'll proceed to the next. We're going to look at day 2, 7 a.m. nurse's progress notes. And it looks like we also scanned this as well. All right. Now, looking into the vital signs, so just carefully look for the changes, those values that really is hinting towards some changes in their respiratory function. Okay, take a look into the worsening, or if there is any, or if there's any improvement in the vital signs. Now let's look into your task here. It said, the nurse assesses factors contributing to the patient's respiratory status. Drag from word choices to complete the sentence. The statement says, the patient's respiratory status is compromised due to blank, blank, and blank. We have the following options: post-operative pain, hypovolemia, allergic reaction, atelectasis, morphine-induced sedation, pulmonary edema, shallow breathing, anxiety-related hyperventilation. Make sure that your answers are cohesive. Now, the first answer, or the first word that we should supply in that first blank, is morphine-induced sedation. This is a big deal, especially for this post-op patient. We know that this is effective pain med for their pain, incision pain, but it comes with a well-known side effect. It's going to slow, or it slowed down their respiratory drive. Even though the patient is still alert, we notice a drop in their respiratory rate. Look into the 12 to 14 range, and the oxygen saturation is dipping into the low 90s as well, 90%. So that tells us that the sedating effect of the morphine is enough to blunt deeper respirations, which will reduce the oxygen exchange. And even if it's mild sedation, it can cause subtle breathing suppression. So we cannot just wait for the patient to look drowsy. You need to watch those vitals closely. Now, the next blank should be supplemented by shallow breathing, because this ties directly into both the saturation readings and the physical exam, because on day 1, the nurse notes shallow breaths, which means the alveoli are not getting fully inflated. So this sets up a chain reaction wherein there's going to be less oxygen to be exchanged, and the lower lungs do not clear out secretions well. It will raise the risk of atelectasis. And think of shallow breathing as the starting point for a bunch of the pulmonary issues this patient is having, especially that she had a recent surgical procedure in the abdomen. They're going to start guarding into that area. Now, the next blank should be supplemented by post-operative pain. This is probably the root of the other two issues. The patient is rating the pain at 6 out of 10, which is enough to make them avoid deep breaths. And when people are in pain, especially abdominal or thoracic pain, they naturally start to splint their breathing. It becomes shallower and more rapid. It can lead to decreased lung expansion and lower oxygenation. And pain doesn't just hurt. It's going to change how people breathe. And if your patient's hurting, you can bet their lungs aren't getting the workout they need. So pay attention to this. So the rest of the options are incorrect. If you selected pulmonary edema for the condition. This would show up as crackles during auscultation. There will be signs of fluid overload. There's going to be more severe hypoxemia than we see in this scenario. But the patient, in this case, her lung sounds are clear and there's no peripheral edema. And the saturation is lowish, but not severe. And the blood pressure and the heart rate are stable. So this doesn't fit the picture. If you selected anxiety-related hyperventilation, yes, the patient has some anxiety, but hyperventilation would mean very rapid breathing rate and respiratory alkalosis in some cases. Now, the respiratory rate here is actually lower, not higher. So go back into the vital signs. We are not dealing with anxiety-driven overbreathing. So this mismatch tells us it's not the cause. So make sure that you've got to pair the symptoms with the vital signs in the chart, because slow breathing rules out hyperventilation, even if the patient is anxious. So you got to be careful. If you selected hypovolemia, this can cause low blood pressure, tachycardia, signs like dry mucous membranes or cool skin. And while the heart rate is a little elevated in this post-op patient, that is unexpected. It's a normal response. There is no strong sign of fluid deficit. And more importantly, hypovolemia doesn't explain the shallow breathing or low saturation unless the patient is in shock, which they're not. So here, don't blame everything on the fluid loss unless the whole picture fits. So the oxygenation issues are not usually the first red flag in mild hypovolemia. If you selected allergic reaction, well, there's no mention of rash, no wheezing either, no stridor, no swelling, all of which would pop during an allergic or anaphylactic reaction. And in this case, the patient is alert and it's breathing without distress. And if you selected atelectasis, this one's quite tricky because it's closely related, but here's the key. Atelectasis is the consequence. It's not the cause. And the atelectasis develops because the patient is breathing shallowly, not the other way around. And we don't have direct evidence that atelectasis has occurred yet. And so we cannot say it's a current cause of respiratory compromise, just a risk for now. So in this test question, all right, let's go to our next test item, number 3. We have the same information for the physical exam on day 1, 8 a.m. The same thing with the nurse's progress notes from day 1, 8:30, 12 noon, 2000. So let's look into the next part of the chart. We have the same nurse's progress notes for day 2, 7 in the morning. Vital signs from day 1 at 8 a.m. through day 2 at 7 in the morning. And the laboratory test results for hemoglobin. On day 1, day 2, we got bilirubin levels on day 2 and the abdominal ultrasound on day 2. Your task this time is to complete the statement. It says here, the patient's condition is most likely due to blank because of blank, ruling out blank due to blank. We have the following options for each blank. For the first one, that's about diagnosis. So it could be deep vein thrombosis, wound infection, post-operative hemorrhage. For the second blank, that's about manifestation. Could be unilateral leg swelling, erythema and purulent drainage, dropping hemoglobin and increased JP drain output. And alternative diagnosis options for the third blank, that could be pneumonia, deep vein thrombosis, wound infection, right? And we also have the fourth option. That's going to be normal chest findings, no leg swelling or pain, absence of fever, and purulent drainage. So what do you think would be the best phrases or words to fill in those gaps? For the first blank, we're talking about diagnosis here. the most likely diagnosis would be post-operative hemorrhage. And the reason for that's because on day 2, the patient's hemoglobin dropped from 10.5 to 9.8 grams per deciliter. And we also see an increase in the drainage coming from the JP. It's about 100 mL of fluid, which is more than what's been previously recorded. And that amount of drainage after surgery could indicate active bleeding. Also, you don't overlook the tachycardia. The patient had a heart rate of 112 beats per minute. It's not sky high, but it's elevated enough to make you think the body is compensating for some volume loss. And your job here as the nurse is to prioritize bleeding as the urgent complication before it progresses to something more dangerous. And anytime you see a drop in hemoglobin and increasing output from a drain, you think about hemorrhage first, especially when paired with vital signs like rising heart rate. Now, the supporting symptom would be dropping hemoglobin and increased JP drain output. This is a downward trend in the hemoglobin. It doesn't happen randomly. It suggests that the red blood cells are being lost somewhere. And when it's paired with the rising amount of the output in the JP, it's said that is serosanguinous. It confirms your suspicion that the blood is not staying in the circulatory system. So these two findings go hand in hand. Low hemoglobin plus increased drainage, that equals to blood loss that you need to act on. Now for the alternative diagnosis, the answer here would be wound infection, because this is a reasonable thing to consider during the post-op period, and this might be where some students get tripped up. But here's why you can cross it off the list, because the dressing that we are noting is dry. There is no purulent drainage, which is also a big deal. The patient's temperature is around 99.9 to 100.2 degrees Fahrenheit, which is a little warm, but it's not high enough to meet the typical threshold that we'd expect for a full-blown infection. There's also no pus, no significant fever, no redness around the wound, and that makes infection a lot less likely. Okay, now we are going to select the exclusion option here. The answer to this is absence of fever and purulent drainage, because these are the red flags for infection, and if they're not present, then it's not the priority problem. And always remember that a mild temperature is common post-op, and it doesn't necessarily mean infection. So we need to see the pus, the swelling, or the warmth, and we don't have any of those in that scenario. And just because there's a small fever, it doesn't mean we call it an infection. You need the full picture, especially purulent drainage, to confirm that. So let's talk about the incorrect options and why they don't work, especially for the post-op diagnosis option. So if you selected wound infection, we already ruled this one. There is no drainage, no redness, no big spike in the temperature. The same thing with the DVT. There's nothing to suggest DVT. There's no unilateral leg swelling, no pain, no tenderness. So the exam doesn't mention anything that would trigger concern for the blood clots in the lower extremities. So here, you're supposed to need swelling, a pain, or maybe even erythema to suspect DVT. So without that, it's just not your leading concern. Now for the symptom options, if you selected erythema and purulent drainage, that's incorrect, because these would point to infection, but they're just not present in this case as well. And the same thing with the unilateral leg swelling. This is what you're going to see in DVT, but again, it's not documented. It's not being reported by the patient, so we cannot assume this one. For the alternative diagnosis options, DVT, again, we have ruled that out. Same thing with the pneumonia. There's no cough, no abnormal breath sounds, no fever high enough to suspect pneumonia. And for the exclusion option, there's no leg swelling or pain. There are normal chest findings. So this would help you rule out pneumonia as well. But again, pneumonia isn't your competing diagnosis in this case. So matching the wrong exclusion to the wrong alternative diagnosis is a common test trap. So make sure they logically pair here. So for this type of question, I want you to prioritize the most dangerous and immediate threat using the objective data, especially when you see bleeding, and always use the entire picture, not just one lab or a vital sign. And make sure your reasoning flows, your diagnosis, especially the symptoms and exclusion, all need to align. Let's have our next item. This is the same physical exam information, nurse's progress notes. Also with this page, it's the same one. Now let's look into the vital signs. Nothing new here. And for the laboratory, so I'm just showing here for you to refresh your memory of what this patient is having. And of course, there's your hemoglobin on day 1 and day 2. It said here on day 2, the nurse evaluates the patient's response to interventions, indicate whether each finding suggests improvement, worsening, or no change in the patient's condition. Each row can have multiple responses. We got this matrix. We got the following findings: hemoglobin 9.8, pain reduced to 4 out of 10, saturation of 94 of 3 liters, JP drain output of 80 mLs, and patient less fatigue. Again, you're going to select either if the condition or finding has improved, or if this is an improvement, or if it's a finding of a worsening case, or if it's no change. So let's look into the hemoglobin of 9.8. What do you think would be the answer here? The answer is worsening, because the hemoglobin dropped from 10.5 to 9.8. And it's not just a drop, it's happening after surgery and in the context of increasing JP drain output. So this drop could be a sign of ongoing bleeding, which is concerning for this nurse. Even though it's a small drop, you got to consider that, because any decline in the hemoglobin post-op should raise red flags when it's paired with the other signs of possible blood loss. And anytime you see hemoglobin going down while a patient has a surgical drain, you have to think about bleeding. So yes, this is a sign that something is worsening. Let's move on to the next finding: pain reduced to 4 out of 10. This is improvement, because on day 1 the patient reported a 6 out of 10, and now it's down to a 4. That means the pain management strategy, probably the morphine PCA, is working. And it doesn't mean the pain is gone, but this kind of drop shows the medication is working as intended, and the patient is more comfortable. And we're not really aiming for 0 pain right away, but a drop in their pain score is a solid indicator that the intervention is helping the patient. Now let's look into the next finding: saturation 94% on 3 liters nasal cannula. This also reflects improvement, because the saturation has gone up from 90% on day 1 to 94 now. But it's important to see that they increase the oxygen from room air or lower flow to 3 liters nasal cannula. So even though the patient still needs oxygen, they're responding to it, and that's what we want. Yes, they still need oxygen, but the higher saturation tells us the lungs are doing a better job, and oxygen therapy is also working. So this is a win. So let's look into the next one: JP drain output 80 mLs. So this is also an improvement, because on day 1 the output from the JP drain was 100 mLs, and now it's 80 mLs over the next 8 hours. So that is a decrease. It's not a huge one, but it's in the right direction. And less drainage typically means less bleeding or fluid accumulation. It's a subtle improvement, but one that we cannot, that what we want to see. All right. And as long as the fluid is not turning cloudy or foul smelling, and the amount is decreasing, we're good. And that's a huge improvement as well. Last, we have patient less fatigue. This is showing improvement. This is a subjective symptom, but do not underestimate this one, because on day one, the patient was noticeably tired, likely due to the pain, the blood loss, and maybe the effects of the anesthesia. And this time, they're reporting that they feel better. They feel less fatigue, which usually means the body is getting adequate oxygen and pain is being controlled. And if your patient says they feel better, believe them, especially if other clinical signs support it. And feeling less fatigue is a sign of progress. So in this test item, when you're evaluating the outcomes, always compare the current data to the baseline or previous values. And also ask yourself, is the patient trending in the right direction? Or are they stabilizing? Or are they worsening? Or are they staying the same? So you got to match the clinical cues to the clinical knowledge of your post-op recovery and the complications to make sound judgments. Let's have number 5.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It says, the nurse reviews the nurse's progress notes from day 2, 7 a.m. to identify the patient's psychosocial and educational needs. Click to highlight findings that indicate the need for psychosocial support or patient education. So we have here the nurse's notes, timed at 7 in the morning, day 2. Blood pressure 148/90, heart rate 112, respirations 12 on 3 liters, nasal cannula, temperature 99.9 degrees Fahrenheit, hemoglobin 9.8 grams per deciliter, nausea resolved after ondansetron 4 milligrams IV, pain reduced to 4 out of 10 on morphine PCA, patient feels less fatigued, epigastric discomfort persists, described as mild, JP drain output 80 ml serosanguinous fluid over 8 hours, decreased from 100 ml. Reduced anxiety after social work consult. Patient states, I feel more hopeful about my recovery. Abdominal dressing dry intact. Continuous pulse oximetry continues. Gastroenterology consult pending. So if you want to read the paragraph one more time, go ahead and do that. This time we're going to highlight those findings that are indicating the need for psychosocial support or patient education. And one of those statements is this one. Reduced anxiety after social work consult. Why? Well, when a patient's anxiety improves after talking with a social worker, that tells us something important. It means the patient was dealing with stress or maybe emotional burden that needed support. And in this case, the consult did not just reduce the anxiety. It revealed that the anxiety was significant enough to require intervention. And that is our clue. This patient likely needs ongoing psychosocial support, not just a one-time conversation. Now, let's talk about education. If the patient feels better after the consult, part of that might be because they finally got clear answers about recovery, could be finances or discharge planning. And we as nurses can follow up by continuing that education. Maybe the patient did not fully understand what recovery would look like or how to manage their JP drain. And so reducing that uncertainty goes a long way in maintaining their emotional stability. So this is a huge one. Now, we are going to highlight this statement as well. Patient states, "I feel more hopeful about my recovery." So this might sound like a good sign, and it is, but it's also a subtle cue that the patient was feeling pretty low before. And when someone says they feel more hopeful, they're actually telling you they were worried or discouraged to begin with. And that's your window to keep supporting them emotionally. And they may still be anxious under the surface, or they probably are unsure of what to expect next. It also opens up a perfect opportunity for teaching, and we want to build on that hope by giving them tools like explaining how the drain works, what to watch for, and when things are considered normal or not. And that helps them feel even more confident, and this will reduce the chances they'll panic if a symptom changes unexpectedly. And the other statement that we should highlight is this one: epigastric discomfort persists, described as mild. So here's why this is key. Even though the discomfort is not severe, it's still there, and that means we need to help the patient understand what's going on. And always, post-surgery discomfort is common, but if the patient doesn't know what's normal and what's a real flag, like let's say worsening pain or signs of a bile leak, they could either ignore something serious or feel anxious about something mild. And this discomfort also connects directly with their history of anxiety. If we don't address it, even a small symptom can spiral into something very huge, especially for a patient who lives alone or has very limited support. So both teaching and emotional reassurance are very critical here. And the rest of the items are not going to be highlighted. So if you highlighted the vital signs, these are vitals that will tell us about the patient's clinical condition. Things like pain or blood loss. It's not going to relate to mental state. And if you selected saturation of 94% on 3 liters, this one's pretty straightforward. It tells us their oxygen level is stable. That's great from a respiratory standpoint, but it doesn't say anything about how they're feeling emotionally or what they know about their condition. So this one is a positive clinical outcome. It's not a psychosocial cue. The same thing with a temperature of 99.9 degrees Fahrenheit. This is a low-grade temp. While we need to keep an eye on it, it doesn't indicate stress or anxiety, nor does it point to a lack of understanding. And this one is a clinical data point for infection monitoring. It's not a red flag for emotional or educational gaps. If you selected hemoglobin 9.8 grams per deciliter, also incorrect. We know that hemoglobin is low, and this is something that we need to keep an eye out, but it's not something the patient would feel emotionally unless they've been told about it or they're experiencing symptoms tied to this one. And if you selected nausea resolved after ondansetron 4 milligrams IV, and since this one is already resolved, there's no longer a distress or any trigger here. And if you selected pain reduced to 4 out of 10 on morphine PCA, well, that's great, right? But unless the patient is experiencing more worry about the pain or asking questions about how the PCA works, we're not dealing with an emotional or educational gap anymore. And this is more about symptom control than psychosocial care. And if you selected patient feels less fatigue, we know that fatigue improvement is a clinical win. But again, it doesn't indicate an emotional struggle or a misunderstanding. So eliminate that one. And for JP drain, output of 80 mLs over 8 hours. This is important for monitoring complications, but it's not a clue for psychosocial care as well. And the same thing for abdominal dressing, dry and intact. Again, that's great news. This just confirms that healing is going well, but there's no psychological distress here. And the same thing with the pulse oximetry continues, gastroenterology consult pending, these are orders and actions that care team is taking, and they're not really associated with a psychosocial aspect of our patient. So we're not highlighting those as well. Let's move forward to our next item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says, the nurse is planning care for the patient on day 2, 7 a.m., post-open cholecystectomy. The patient's hemoglobin is 9.8 grams per deciliter, saturation is 94, on 3 liters nasal cannula, pain is 4 out of 10, and she reports mild epigastric discomfort and reduced anxiety after a social work consult. Select all nursing interventions that are appropriate to address the patient's current condition and potential complications. So here's your nursing actions. What do you think should be the best pick? It said, notify the healthcare provider immediately about the hemoglobin drop to 9.8 grams per deciliter. This is one of those correct answers, because if there is a noticeable drop in just a day, you gotta need to act here. This is especially when this is paired with the JP drain output and a tachycardic heart rate. This strongly hints that there is ongoing blood loss. Again, this is your top priority to report quickly, so the provider can step in and determine whether the patient needs a transfusion or another intervention. So this is not wait and see moment. This is a red flag, and this should not be ignored. The next intervention that you should select is teach the patient to monitor for signs of jaundice, such as yellowing of skin or eyes. Because when they have slightly elevated bilirubin and there is perihepatic fluid seen in the ultrasound, that corresponds to bile leak. That is a real possibility because of the mild epigastric discomfort, and also it's going to make the problem a little bit worse here. So when you're teaching the patient to look out for those early warning signs of jaundice, this is going to empower them to take action early if things start to go south. Plus, it's going to help ease their anxiety by giving them tools to feel more in control of their recovery. Now, you're going to select this one as well. Encourage incentive spirometry every 2 hours to prevent atelectasis, because after surgery, and especially with morphine PCA in use, they are at risk for shallow breathing, which means their lungs are not expanding properly because of possibility that there is central nervous system depression or respiratory depression, and that is a setup for atelectasis. So having them use the incentive spirometer every couple of hours will keep their lungs open. It's going to help prevent complication, right? And we also have this one to select: schedule a follow-up social work consult to address ongoing financial stress. So let's not forget about the emotional and financial side of recovery. This patient already benefited from social work consult. Her anxiety improved and she feels more hopeful. But her history of anxiety and living alone means she's still vulnerable. So you got to keep that support going by scheduling another visit. And it's not only compassionate, it also helps with long-term recovery and adherence. This one you should select. Elevate the head of the bed to 45 degrees to reduce epigastric discomfort. Sometimes the simplest changes make a big difference, and mild epigastric discomfort can stem from post-op inflammation or even early signs of a bile leak. And when you're raising the head of the bed, you're reducing the pressure in the abdomen and helping digestion. This is one that is a low risk. It's high reward intervention that can ease their discomfort while the team waits for the specialist input. So the rest of them are incorrect. Now, if you checked on increased O2 flow to 4 liters nasal cannula, you might think that this is helpful, but it is unnecessary because the patient's oxygen saturation has improved from 90% to 94% on 3 liters. There is no sign of distress or drop in saturation that would justify cranking the level up. And remember, oxygen is a drug. More isn't always better. And going too high without cause can be harmful for this patient. They can develop oxygen toxicity as well. If you selected administer ondansetron 4 milligrams IV for persistent epigastric discomfort, well, this is not going to work because ondansetron is intended for nausea, not for generalized stomach pain. And in this case, the nausea already resolved and the ongoing discomfort could be from the inflammation or maybe a bile leak. And giving the ondansetron just because the patient has discomfort, not about nausea, is not appropriate. So instead, support her symptom in other ways like positioning. Now, if you selected to discontinue the morphine PCA due to the risk of respiratory depression, we know that morphine can do that. It can also suppress their breathing, but the patient's vital signs are stable. Their respiratory rate is normal and saturation is fine. And take note that her pain has gone down to 4 out of 10, which means the PCA is doing its job. And when you're discontinuing it too soon, it might cause pain to spike again. It's going to make her less likely to take deep breaths, or it's going to make her less mobile. And this is exactly what we're trying to avoid in this case. And if you're selected, prepare the patient for an urgent surgical consult for suspected bile leak. We know that a bile leak is possible, but the situation isn't urgent yet. There is no peritonitis going on. There's no severe pain, no unstable vitals. And the ultrasound showed mild fluid, and there's already a gastroenterology consult in place. So they're aware about the problem. And if you're jumping to surgery too soon, this can cause unnecessary alarm. And you got to be reminded that our job here is to keep monitoring and support the patient while waiting for the specialist recommendations. So don't jump the gun. Alrighty. I hope that you're able to understand all the rationales here. And I am commending you for the fantastic work in staying with us for this session. You have sharpened your ability to recognize the critical cues, prioritizing those interventions, and evaluating the outcomes, because all these are keys to mastering the next gen NCLEX and delivering safe patient care. So I want you to keep practicing these unfolding scenarios to stay on top of your game. So if you find this review session helpful, do not forget to subscribe to the YouTube channel for more NCLEX prep content. Also give this video a thumbs up and share it with your friends who are reviewing for the NCLEX. Thank you for watching, and I'll see you in our next review session.